Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site.
Welcome back to Unraveled, Understanding Chronic and Complex Illness. I am Eileen Ruhoy, and I am with my co-host,
David Kaufman, hi.
And we are very excited today because we have a lovely guest who is a patient of mine, and her name is Dayde McLaughlin, and she has agreed to join us to tell us a little bit about her story and her medical journey, because I think it really resonates with a lot of patients that we see. All the years that she tried to get doctors to take her seriously, and how she finally arrived at those that can help diagnose her and help treat her symptoms, and what the road has been like since that time. And so welcome, Dayde.
Well, thank you very much.
You're very welcome. So, and you also play a big role in, out here in Washington State, there's an EDS group, and you play a big role in that. I know that you help mentor people. You are a very active member of that group, and so you've gotten very much involved with the EDS world because of your diagnosis. So I would love to hear more about that. In fact, I don't know a lot about that about the work that you do on that advocacy front. So, let's first start by just having you tell us all about you and some of your story with regards to your medical history, or as much as you're comfortable sharing.
Right. Okay. So I think my symptoms, if I look back now retrospectively, I could see a lot of symptoms over the years. But it wasn't until 2018 when I had a knee surgery that seemed to trigger kind of a cascade of events where it started with my ankle. And I was desperate. I was like, what the heck is wrong with my ankle? And I had always been in PT, which I thought was normal. So I was very active, I was very athletic, I was in shape, and I spent my life at PT, and I was always injured. And I just thought, well, that's just what happens because I'm an active person. And I got this ankle issue, and they said, oh, you have a compressed nerve. Oh, you have this. Oh, you have that. Went to this podiatrist, that podiatrist, and my PT said, I'm sure it'll be fine. Then I had a little ankle brace for a while, and then my back started to creep up my back and my shoulders, and before you knew it, it was pretty systemic, and I didn't know what was going on. And so the first person I went to, this is kind of an interesting story, and I'll circle back because it was a physiatrist. He's very good. And he said, well, I know what's wrong with you. Your ankle is connected to your hip. And I said, yes. And he said, so I will give you a shot in your hip, and then that will fix your ankle. I think they're connected. I said, great. And so I did that, and it didn't work. And I said, no, and so he said, well, maybe try this. And he tried an ablation. He said, well, now we'll do an ablation. So we did an ablation.
Of what?
My back.
Oh.
Yeah.
You mean a nerve? You ablated
yeah, nerve ablation.
What nerve?
L4, L5, right down. And
he kept connecting the dots.
He kept connecting the dots. He kept connecting the dots, and then I went back and I said, gee, I don't, this, I don't know why it's not working, but it's not. And so then he said, well, you need Cymbalta. And I said, well, why do I need Cymbalta? He said, because it's brain pain. So we went to the brain pain connection, which is fine. And it's valid. So that's the irony of all of this. There's a grain of truth in lots of this stuff. But is it true for this situation?
Right.
And so I was very fortunate. One of my best friends is a very well-known psychologist on the East Side. And so I went to her and I said, it's fine. If that's what I need and where I'm at, that's good. And what do you think? And she said, not only no, but, heck no. She didn't quite say that, but, and she said, no, whatever is going on with you, I promise is medical. And she deals with chronic illness and patients with all that. She goes, it is not. She goes, you do not need that. So I'm back to that doctor. And then he said, well, then it's just in your head. And, you know, off I went. And so I went to my primary doctor, and I had known her for like 25 years. She was my husband's hospice doctor. I mean, we had been through the mill. And so thank God. And she said, if I didn't know you as long as I have, I wouldn't believe you. But I do believe you because I know you.
Think about the patients she doesn't know.
I know, but this is why I want to mention that.
Yeah.
That, and she's and she said, I know something is very wrong. She said, it's obvious to me, but I don't know what. And I thought, God bless her, right? I mean, that's a great thing to say.
Yeah.
You don't know when you don't know. And I was really appreciative of it. And I was appreciative that she believed me.
Yeah.
You know, and so she goes, okay, go to this other physiatrist. Ay. And so I went to this guy, doctor, and he said, no problem. Oh, and I had also had an injury to my shoulder. And he said, no problem. We're just going to shoot you up. That was it. And I said, what are we going to do? And he said, we'll just, every 3 weeks, we'll give you steroid shots. You can do that for about a year. I know. You can do this for about a year, and then you got to stop. And I said, but I do have osteoporosis. Is that a problem? And so he said, nah, it'll be all right. And so I was like, so we started down this road. It really, and I do understand, because you get desperate. The more you decline, the more I chased it. Mm-hmm. The more I chased it, the more I was willing to say yes to things, even if the little voice in the back of my head said, is this really a good idea?
Right.
Well, I think one of the points here is, you're clearly, I don't really know you, it's just for the audience, but just hearing you speak, you're clearly a sophisticated, educated person and patient, and yet you still, like so many people, understandably, are ready to just believe the doctor.
You want to be well.
You want to be well, and you want to believe that this person in front of you, who's gone 8 years of training and 4 years of residency and God knows how many hours a day doing all that, they must know what they're talking about.
Right, and you talk yourself into it too. Right. You know, and that is very true.
Yeah. Right, you convince yourself that, well, they're the doctor and I'm not, so that must be what I need to do.
Right.
Right, and I do appreciate, and people that are educated and have specific areas of expertise, and I'm very aware that I do not.
Right, but you have your own area of expertise, and you remembered when you used to work at Boeing.
Yes,
and you had your own area of expertise that people relied upon you to guide them. Correct. And then you relied on other departments. So it's very similar in medicine, even amongst doctors. Like I rely on other specialists, as you do, for their expertise in their area. And when they say something to me, I have no reason to believe that that's not accurate, right? So it's sort of a similar kind of respect I think we give to people with other areas of specialty, even
as
in medicine and out, as we should.
I think as we
that's
should.
That's actually how I think the
that's
world
how it
turns,
starts.
Right.
Yeah, that's how it starts until proven wrong.
Exactly.
Right? And then that's okay. So we started down that road, and then I thought, this is not working. And I said, that's the first time I ever had an argument, I think, with a doctor. And I said, it's not working. And I said, I really think something systemic is going on. I know something is wrong. I don't know what. And he said, you are ruminating on your pain. That is your problem. And so I said, well, I don't think I'm ruminating on my pain. And I said, I think psychologically I'm okay. I mean, I understand. I know what I know, and I know what I don't know. And I know that there's something wrong. That's all. I don't know what. And I said, would you refer me to UW? And he said, okay, I'll write you a referral, but you'll never get in. And I never did. So he was right. Was right.
Because, hospitals will triage out.
You have to plead practically to get into the academic place.
Yeah. So
what department was he referring you to?
Neurology.
Okay.
And so I never heard from them, actually. I got one phone call once, and then I never heard again. So then my friend has patients who have EDS. And so she said, we know this particular person, and there's this doctor called Dr. Singh, and when, nobody else can figure you out, you go see him. And I said, great, I'll call him, and I did. And I had gone to other doctors
And
too.
he's a physiatrist.
He's a
just in case people
physiatrist.
don't know him.
And he's, very astute with EDS and very familiar with it. And I went to many other doctors as well, but for the sake of time, those were kind of like the highlights. Or you would go, one more was a shoulder doctor because I got bilateral frozen shoulders all of a sudden. I don't really think actually they were bilateral frozen shoulders, but anyways, I was sent to this shoulder doctor, and he said, well, that's okay. I'll just put you under anesthesia and I'll just rip your arms. And I went, oh my God. And I said, I have EDS. And he goes, I don't do EDS. I said, do you think this has anything to do with my neck? He goes, I don't do necks. And I said, well, aren't necks and shoulders kind of intimately related? And he said, well, yes, but I don't do them. And he said, so do you want me to pull your arm? It might tear your muscle. I said, it would rip my arm off. I said, I'll pass, thanks. So, but these are the things that people, and you have to handle them with some grace, too.
Of course.
Right? It's really important to have
Yeah, and I'll
the
add,
grace.
especially as a female.
Yes. I just think it's important because we have to navigate the waters.
Right.
No matter what, even if it doesn't matter, we still have to navigate. And we're all human beings, and they are too. And in their position, and I will say this, even this doctor that wanted to shoot me up, he thought this was in my best interest.
Mm-hmm.
He felt that this was the right thing to do. And so I was challenging him. And I did challenge him, and I said, this is not true. And so when I did get diagnosed, I did send him a little note. So anyways, I went to see Dr. Singh, and it took 20 minutes. He did the Bates scale, and it was 8 out of 9. And he said, wow. And I was 65 at the time. I'm 70 now. So it was like, he said, wow. He said, I've got the thing for you, Muldowney protocol. I know a PT. She's great. She's got EDS, blah, blah, blah. She was great. Muldowney protocol is great. I did do that for 6 months, and I failed. I failed
meaning,
PT. I failed PT.
But what do you mean by failed?
I never got better.
Didn't get better.
I did not progress.
Okay.
And so they said you failed. And so, but the PT was so great. She knew Dr. Singh. So I was, again, serendipity, very lucky. And she really cared about me because I try. I am like, I will just try. And she said, you're trying so hard. And really the faster I went, I was just regressing at a slower pace. That's what was happening. And so she said, something's wrong. She goes, I think there's something neuromuscularly wrong. I don't know. She said, when are you going to go see Dr. Singh again? I told her, I said, can I come with you? I know him. She came from Bothell to Seattle.
I didn't know this part.
At 9 o'clock in the morning.
She joined you for your appointment with Dr. Singh?
She wanted to
Wow.
make sure that Dr. Singh understood that there was something really wrong with me. She said, this is beyond EDS. She goes, you're beyond. I said, oh, thanks. And so we went down and had the conversation. He was like, and he wanted me to do some things. And she said, she cannot. She's not. I can't. And I said, I can't. I wish I could, but I can't. And so he said, well, you need Dr. Ruhoy. And that's what he said.
And the rest is history.
Dun, dun, dun. And so it was like, really,
can wrap up
if you
now.
don't know him, he's just the most energetic guy. And he hopped up. He goes, I'm going to call her. He goes, stay here. That's why, stay here. And I said, okay. He said, I got her voicemail. It's not a good sign, but we'll see how it goes. Maybe she'll call me back. And I said, okay. And you did. And you said, okay. And that's how I got to you.
Right.
And by the time I got to you, it was to the point where if I wanted to take my left foot and put it on my right foot, I could not do that.
You couldn't lift it.
I couldn't do that.
So I'm going to interrupt you for a minute
Sure,
just
of
to
course.
make some points for the listeners.
Of course,
okay?
please.
The first, which you've said, and I want to reiterate it, is, as you know, your story is typical for virtually every patient we see. I see patients who will tell me it's 5 years or 35 years that I've had these symptoms, and I've seen a dozen doctors or 24 doctors, and all my tests are normal. They try, they listen, but they don't know what's wrong. And usually I end up being told to take Cymbalta or see a psychiatrist or a psychologist. And an important takeaway from your story, which people need to hear, is we each know our bodies better than anyone on the globe, right? Nobody knows what I really feel or what you really feel, but you know your body. And if you know something's wrong, something's wrong. And if you are with a physician who kind of not getting it, yes, all the good things you said about physicians, but at the same time is precious, and don't take too long to say, well, this person is trying, but they don't get it. So that's the first thing. The second thing is, and I'm sure you're going to go into it, but I guess I'm doing this as a sort of preamble. You were, quote, fine until 2018, and you had surgery. But in fact, you told us just earlier, based on your history, you weren't fine. You had joints that were not cooperating with life. All right. All right. But that was fine. I mean, that was your life, and you probably, the term I use is background noise. You just learn to live with it. Lots of people have problems. I have some problems. No big deal. I can still go to Boeing, and I can still play tennis or whatever. But something happened in 2018 that changed the game. And it's a crucial thing for people to understand, that they can have a lifelong set of problems which are background noise. They don't disable, they don't impair functionality to a significant degree. And then something may happen that turns that dripping faucet into a waterfall.
Correct.
And it's usually a surgery, an infection, physical trauma, emotional trauma, something like that. It's an important concept for people to understand.
I love that phrase,
I do
background
too.
noise, because that's exactly what it is.
Yeah.
It's just sort of like you deal with it, you know? And sometimes you convince yourself that it's just part of the aging process.
Right.
Oh, well, I'm
Right.
older now.
Yeah, I convinced myself it was not only that, but normal.
Right.
Exactly. That's
I
what
thought it was my
people
normal.
do. Right.
And I knew, and I was very, very busy.
Yeah. Especially after you see doctors who
I
don't
was,
say anything or do anything or find
Right.
anything.
Right,
But
exactly.
I was traveling all the time.
Right.
I was schlepping luggage everywhere. I was.
So sure your shoulder hurts from schlepping luggage,
Right,
and
that's
sure
it.
you get tired or whatever because
That's
you're
right.
older.
Yeah.
Yeah, right, exactly. So all that, yeah.
I have a thing I say to patients, especially if they're older, like you and I. Okay,
Mm-hmm.
when they say, "Well, yeah, I feel that way, but it's because I'm older," and I basically say, "I want you to know I will never ever accept that as an explanation for a symptom." And I think if we could convince every doctor to just learn that statement, it would really take us a long way.
Yeah.
Yeah.
Oh, I 100%.
I mean, I'm
agree.
biased because I'm older, but still.
Well,
Well,
I think
I'm
that the
biased,
way
but-
doctors even see what's old and what's not is so. I mean, I remember, working in the hospitals and having, 40-year-olds come in and saying, I used to be able to run 10 miles, and now I can't even run 5. And I remember like other neurologists saying, well, you're 40 now.
Exactly.
Like,
It's like, what are you talking about? All right.
so
I'm sorry
really,
to
and
interrupt
so
you.
it's
No, please.
subjective, I guess,
Yeah.
what old
Right.
is. But go ahead.
Right.
Sorry.
Oh, no. But I think the big point is during that whole process, I continued to digress and digress, no matter how hard I tried. And I think sometimes as a patient, that's really terrifying. So I
Yeah,
do want
sure.
to say that.
Sure.
Because you're really chasing something. You're saying, please, please fix me. I'll do anything.
Right. Well, I mean,
Fix
I think
me."
what you were describing, how you couldn't move your left leg towards your right. I mean, at that point, you realize, okay, this is not normal, and that must be scary
It
to
was.
recognize that what the background noise that you had been just sort of accepting as normal was clearly not normal now to you, and that's got to be terrifying.
Yeah. And I was kind of now in water therapy because I couldn't handle land therapy.
Right.
And I was like, oh my goodness gracious. So, anyways, I came to see you, and 27 tubes of blood later, I remember that.
It's a good thing you didn't come to me because I usually 35 to 40.
Yeah, I know. Yeah. I was like, oh, anymore. So, yeah. And, and it was just great. And I think one of the things that is just so, I really have to say this, so incredible. I don't know you that well either, but I've watched you on podcast a lot, so I've gotten to know you that way.
Yeah.
And, brilliant, brilliant doctors and brave. I mean, you are on the bleeding edge and you're willing to be there, and thank you.
Oh, well, thank you for saying it. It's hard. It's a hard place to be sometimes.
It's a hard place to be because, you're kind of outside your tribe a little bit, I would imagine.
Yeah.
Right? And you're pushing all the cultural norms, and you're pushing institutional, not even beliefs, constructs. I would say
But it's
constructs would
also
be better.
exciting and challenging.
It
Yeah.
is.
I
It
mean, I
is.
love
It
it.
is. Paving is really fun. Innovating is
Yeah.
really, really fun.
Exactly.
Yeah, I agree. But So, I think that in the chasing of it, by the time I got to you, I was not too far from being in a wheelchair. I mean, you think about it.
Yeah.
And I was really athletic,
Right.
I was the Energizer Bunny on steroids, so I went from that to this. And you were you're very compassionate and caring, but insightful. And I think what I do want to say is you really look for the root cause, and you're trying to say, what is causing all of this? And, the human body, talk about a complex integrated system, my goodness.
It's its own ecosystem.
It's its own ecosystem. It's like, my gosh, where do you even start? And so it's just stunning. I love listening to you guys. I just find it fascinating. But it's really stunning, and there's not many people that do that. I will say even the people that are EDS-friendly doctors, and they're wonderful, they're more symptom-based, and that's appropriate. And we need that.
Yes.
We need that, and it's really terrific. But what really helped me was somebody understanding how my body worked.
Right.
So
So talk about the different treatments that you've tried, whether it was recommended by me or others, that have worked a little bit or not at all. And then, were you going to interrupt me?
Of course. That's what I was born for, to interrupt you. I was going to humbly suggest, before you dive into treatments and responses, perhaps talk a little bit about what you thought was wrong.
yes.
Oh, well.
Yes.
I think,
because what was your impression?
mean,
Because
'cause she-
it's a relationship, so we should talk about our relationship.
Well,
Okay.
and you've always had EDS from day one.
I know.
Or from
and
minute
now,
one.
yeah.
So that can't be the answer here. I mean, that's not the punchline, I'm assuming.
right.
So what was else?
Well, her
what
symptoms
else
were
was
clearly,
wrong?
and let's point out that this was many years ago that we first met.
Mm-hmm.
So I did not know what I know today, right? Because our education is
right,
constantly
constant.
evaluing.
And that's
right?
important for people to understand that
absolutely.
it's a journey.
It is a journey. It's been a journey for us. It's been
Yeah.
a journey for
So
patients.
we'll talk about our journey.
Yeah, exactly. So when we first met, we had a very long conversation, and I started to get to know you, and I did that entire workup. I always say that I want to understand the physiology of the patient first and foremost before I make any strong recommendations either way. And obviously, I did the panel about your mast cells, which were proven to be very active and reactive. So we know that you had mast cell activation syndrome. And then your symptoms were clearly your symptoms were clearly POTS. You had a diagnosis of POTS because your symptoms were consistent with that. We did autonomic testing, and we proved that. We did the tilt table test.
Yeah, it's okay.
Sorry, David.
Don't worry, I won't slap your wrists.
And did we do imaging at that initial appointment? I actually don't remember because I think way back then I wasn't as savvy on the craniocervical
Right,
instability,
right.
and so I think I held off on that kind of
Yeah.
a workup.
You were going to do the traction,
Right.
but I was terrified.
Right, you were
So-
terrified of the traction.
So again, for people listening, what I want to emphasize here is you always had EDS,
Yes.
but you walked in to see Eileen and you walked out suddenly with 4 out of the 7 diagnoses in septet right away.
Yeah.
right?
Yeah. She
You
was
had orthostatic intolerance. You had mast cell activation syndrome. What else did you say?
She had EDS.
Well, EDS. I mean, the point I'm trying to make, and I keep making it,
Possible
it's probably
CCI.
people are sick
Right.
of it, is look for what's causing these labels.
Yes.
What is driving the illness in our patients? So, all those doctors you went to, nobody checked for orthostatic intolerance. Nobody even thought of
They
mast
didn't-
cell except, that was later. Okay, nobody even thought
Right.
of mast
We
cell.
did right. So not on that initial visit, but I did eventually do a skin biopsy. She has small,
Small
fiber
fiber, okay.
neuropathy. So with positive synuclein, right?
I don't think so.
Oh,
And
sorry.
probably some of those things you've had your whole life as noise,
Right.
and they didn't interrupt your functionality. I mean, I see that all the time in our patients.
Right.
They'll give little hints of allergies to medication, or once in a while I feel dizzy, but it never stops them.
Right.
So, and again, it goes back to
Yes.
the thing of something about that surgery flared inflammation, and everything went to hell after that, basically.
My hypothesis is the anesthesia.
From the knee surgery. Yeah, I agree. Well, your body, because of the mast cells, your body has clearly shown of high sensitivity to things that are injected into you and infused into you, like the recent reclass, which we'll get to. But
Mm-hmm.
so we found that there was mast cell activation. We found that there was POTS. We found that there was small fiber neuropathy. And so we started to treat, and you had response, which was the most exciting part.
Right.
And, over time, it was an incomplete response, but it was still a response. And you still had symptoms despite the fact that they had improved. And then we decided to move to IVIG. And that has really been
A game changer.
a game changer for you.
Yeah,
And that's
because-
what was so exciting when we saw how well it was working for you. Like, to me, like that, it proved, first of all, there is an immune mediated component to all of your symptoms. The fact that so many of those symptoms responded in kind. But we still had to manage your mast cells, right? Because the IVIG has been somewhat of a rocky road. We had to be very careful as to the dosing that we were doing and then the frequency. And we've sort of tweaked it many times along the way. But we continue on with the IVIG. And I will say, you've been a trooper, for sure, because you are more motivated than many patients, especially, in response to the symptoms that you've had with the IVIG with regards to adverse effects. Because you did suffer early on because it's a very viscous fluid. It's very hard on an EDS body, frankly, largely because those vessels are so friable, and it's just like sludge in the system, right? So it doesn't really know what to do with this like dense liquid, and sometimes it just sort of falls apart, and then lots of things get into the systemic bloodstream, and then if you have mast cell activation, there's an entire response that could really be hard for a lot of patients to tolerate, and some patients will say, I'll never do that again. But you weren't one of those, and you were willing to sort of, I would say, let's do it like this next time, and you would say, okay. And so it was really easy to treat you in that regard, because I always had ideas. And so
Right.
you were, and you continued on with physical therapy. I mean, you did everything I told you to do, basically.
Almost, not everything, but pretty much.
Yeah.
I think there's a lot of components to being well, and I think one of them is joy.
Yes.
And I think it's important so I'm going down my own bunny trail, but as we go on the journey to wellness as a patient, to have the balance of not only, do this, don't do this, don't do that, this long list, which can seem overwhelming, and then balancing it with some joy. And so that's where, as an individual, I think what you're talking about, individual decisions, right, about what's enough and what do I want. And I really want to get well, and that means get better, be better than I am.
Right.
That doesn't mean to get cured.
Right.
I
So I
like
wanna be
your
clear.
use of the word joy there in describing how one can react to, live with one's illness and the changes and improvements. And
You just have to shift gears.
you have to shift gears, and sometimes you need help in shifting gears, not
do.
maybe you, but other patients.
Oh, of course I do.
I often have patients who I get on the appointment, this would be telemedicine, let's say, and the minute the screen opens up, I know there's been progress. This patient is so much better just looking at them, but they don't report that. Right? Sometimes they just say, well, I'm the same, I'm tired and brain fog and I'm having trouble doing it. And as we talk, it's clear that that's not what it used to be. And I had a great example of it this week. And I'm saying this because I think it's really important as part of what we do as physicians, not just to prescribe interventions, but to help patients acknowledge and become aware of their improvements. So I have a patient who's been sick for literally 10 plus years. I've been seeing this woman. And I won't go into the whole history, but in this visit, the minute she logged on, it was like, wait a minute, is this the right patient? She looked completely different. She reported most of the same symptoms. But then I said, well, what have you been doing? And she said, well, I've been driving and going here and there, and I've started going to the movies. And it's like, I'm listening and thinking, wait a minute, this person was locked up in her room for the last 9 years. And she's describing all this, and I basically pointed it out. And, I think it means a lot for the physician to help explain that if the patient is kind of stuck in the old ways of thinking. So, just a side comment.
Yeah.
No, it is
I think
very
it's really
true.
important.
I mean, patients over the years have proven that if they're able to sort of bring themselves out of that place of their chronic illness, they find other meanings of life, I guess, is a best way of describe it. And you can see it sometimes, the change in their acceptance of their limitations or acceptance of their illness, or even motivation and willing to do things to try to get them feeling better or improving their symptoms. And, so but it can be hard for patients because
it can be
it's
very
such,
hard.
It is hard.
it's such an obstacle when what you thought was your life is not your life any longer.
Yeah, and I
right?
think patients or people with any illness will often think of it, approach it as all or nothing. Either I'm all better or
Right.
I'm not. And
That is so true.
and it just doesn't work that way, number one. And number two, another thing that I encounter, and I'm sure you do, is let's say the patient has 9 things. I'm just making this up. Well, 4 of those may be much, much better, but the other 5 are still dominating their life, and they will say, I'm no better. And it's important to recognize that's not completely true. And that statement from me as a physician is not saying it's in your head or that you're nuts or something. I'm pointing out that, yes, you still feel badly because you have these 5 things, but these guys are gone.
Right.
And that means we can get rid of those too. We just got to keep working. And it's important for you to see those differences.
Right.
Yeah, I think it's critical.
Yeah.
I mean, I think it's really, really critical.
And was your, I don't want to say recovery,
Sure.
but was your improvement, was it stepwise? Was it slow? Were there spurts?
So it's pretty much a little engine that could.
Yeah.
I mean, it really was very, so how it went was I started, PT, and I got out of the water back onto land. And so I'll just do that first of all. And this is in concert with the IVIG. You also prescribe, because I had a lot of neuromuscular constraints and weakness, and it was really, really limiting. Really, really limiting. So you gave me, and I forget the name of it. I always begins with a P.
Pyridostigmine.
Yeah. Gave me that, and that was helpful. I mean, a lot of different medications, plasmapheresis, IVIG, PT, all of it together really helped. And so what started what, right? Chicken and egg.
Right.
And I would say as a patient, because I tried it, I'm all about experimenting. So, and I would try PT because in my mental model was moving is important, and moving makes me feel better.
Yeah.
I mean, I just like to move.
Yeah. You've always been athletic.
I just like to move. And so if I could get that going, if I could find the end of the string, I kept trying to find the end of the string. And it wasn't until I had the foundation that I had the end of the string. And then I could start improving on the PT. Before that, I was a hamster in a wheel, to be honest.
That's
but
very
I stayed
common.
on that wheel, boy. I stayed on it, but I was just
And that's a
hamster on
testament to obviously your motivation and your dedication to your health. But it is very common, and often I even remember when in the hospitals when we wanted to put patients in inpatient rehab, if they weren't able to engage in 3 hours of physical therapy, then they wouldn't be accepted, because then it would be just a waste of time. Because unless you can truly engage with the exercises that physical therapy and physical medicine and rehab try to do for you, then it's no point in being there. So you try to get patients to a point where you are able to engage, where you can actually receive the benefit.
Right.
And I hear what you were doing it regardless, and that's why you were on the hamster wheel.
Right.
But that's not an uncommon kind of approach to rehab in general, physical rehab, that is, rehab in general, is that you want to make sure the patient is able to be a willing participant in the exercises that the physical therapist tried to guide in. And I do think that's important. And insurance won't even cover inpatient stays if they can't engage in 3 hours of therapy, which of course, why should the insurance care or not? But but yeah, it's so.
But it was because of you that I could get the end of the string.
Right.
And then the PT, and I found a PT, she's just wonderful. And she was so invested, and she got motivated by me, which was great. And now she's kind of dedicated a lot of her practice to EDS.
Yeah.
She said, I get so much satisfaction out of improving quality of life. And
That's
I said,
fantastic.
really? I said, it's wonderful to help somebody. They had surgery, right? They had their knee replaced and rehab them back. That's awesome and needed and important.
Yeah.
And I said, but there's also, what about helping people have a quality of life?
Yeah.
I mean,
absolutely. Absolutely.
To me, that would be, personally a lot more satisfying.
Yeah.
And for her, it is.
Yeah, definitely.
So she's just been with me. So a year ago, couldn't do that pretty much. And now I'm climbing 5 flights of stairs a day. I'm walking, and I can walk more. 45 minutes with hills.
Right.
You know, I do about, and I'm really dedicated, so I do about an hour and a half of stuff every day to kind of keep me going. But I'm just very grateful that I can move, because I know that exercise is so important.
It is.
For my wellness.
Right.
And for me to be on a journey where I can get even better, and that's how I look at it. I just want to be even better.
Yeah.
I don't know what better really looks like. I don't know the end state, and I don't really need to. I just need to know that I can maybe be even better. And for me, that's good.
I think you can.
Well, and can continue to get even better.
Right.
Right.
Not just do this, but do that.
Right.
And it is, and sometimes I feel like the stock market, you know, I kind of do this.
It's an image I use all the time.
But the trajectory's in the right direction, you know, so I'm all right. I'm okay. I'm okay with that.
Right, but
So
we
we had
still
some
know
big
that your mast
setbacks.
cells are still hyperreactive, right? So talk about when you had gotten an infusion of the reclast, and you were on IVIG already.
Yeah, I was
so
on
you were sort of stable and with some improvement still, you know, incrementally, but moving in that trajectory.
Right.
And then because of your osteoporosis, you had an infusion of reclast, and your mast cells were not happy.
Right, and that's because I had a reaction to Prolia. Remember, I had the
Right.
drug rash
That's
all
right.
over my body.
That's right.
And she
That's
looked, I remember she came in, I was doing plasmapheresis, and she said, you have a drug rash. And she goes, you're not doing drugs, are you? And I said, well, I'm doing a lot of drugs, but no, you know. And then you said, here. And then you had the little bottle, said, here's a skin biopsy. And then she said, it's the Prolia. And so
Yep.
I had to get off the Prolia. So that's how I got to reclast.
Right.
And so this endocrinologist said, you'll be fine. And so when I wasn't fine, round one, I called their office and I said, I am terribly sick. I need to talk to somebody right away before I called you, because I thought I'd go through the appropriate channels. And they said, well, you know, we'll put you on the list. And I said, don't. No, I'm like very sick. Like I probably should be going to the ER sick, you know. And they're like, well, we'll put you on the list as fast as we can. I waited an hour, called her back, and she goes, well, if you want me to put you on the list again, that means you go down to the bottom of the list. That was her call.
Wow.
And I'm not going to name this doctor's name, but and so then I texted you and said, you, like right away, Zofran, and did that. And then over the next days, I think I talked to you once or twice a day. I mean, you were really worried about me. I know, I could tell.
Yeah.
I was worried about me, and I was really worried.
Yeah.
And it's the first time I felt like I was imploding, literally imploding.
Well, part of the problem is that once the drug is in you, it's in you.
Yeah.
You know.
Yeah, and I was just. And she said, "You'll get through it. You'll get through it." And I'm like, okay. And you know, so we did that. It took a month to turn it around. It was a long time, and it was really, really difficult. And so this endocrinologist ended up calling me the following week, and it was a CYA call. You know, I'm pretty good at reading people. And so she was like, and I said, and I said, you know, here's what Dr. Ruhoy did, because she said, what did she call you? What did she say? A weirdo.
Oh, that's nice.
Yeah, she said that you were a weirdo. And I said, she's not a weirdo. She's brilliant. She's very well educated. And it's because you weren't following standard protocol by her definition. Right. That's what it was. You were out of the box. And so therefore you were out of the box, and therefore you were 3 sigma. You were uncontrollable.
Wacky.
Wacko.
Wacko.
Wackadoodle.
They don't use quack as much as they used to.
They use wackadoodle.
Yeah, they use wackadoodle,
I say
wacky,
wackadoodle
weirdo.
all the time.
Yeah. And then I said, so here we are. And I said, and the person who now almost killed me was you. And the person who saved my life was Dr. Ruhoy. And I did say that to her. I said, I just want to mention that.
That weirdo.
Yeah, the weirdo.
All I did was give you some Zofran and some Benadryl, and I think
No,
maybe...
you gave me, I forget the name, it began with an I believe it was for like severe inflammation. I mean, my thought my whole body was going to explode.
Oh.
It was again with an I. I had to stand up.
Indomethacin?
Yes.
Oh.
That's what it was.
Yeah.
You gave
it's an
me
NSAID.
that.
I mean, anyone
Then
could
you-
have
you
prescribed
doubled-
that for you. Yeah.
Well, if they knew to
Yeah.
Well, she paid attention.
She
Yeah.
paid
I
attention.
listened
Yeah,
to
you
your
were paying
symptoms.
attention. You were listening, and you were responding. You doubled up my cromolyn. You went from
That's
5 to
right.
10.
That's right.
Yeah.
Yeah.
And you added, say, take Zyrtec, take this, take this. No, you added
Yeah.
a bunch
No,
of
I-
stuff.
I
had
threw
a,
everything at your mast cells.
yeah, I had a list. I had a list, you know, and you said, and then finally we did steroids as well.
Right.
Because my mast cells were just mad.
What's the dosing in Ricklast? How often is it given?
I don't know. I mean, I don't use it.
Well, for mine now, it's once a year, but for me, it's never again.
No, I know that. I just meant in terms of it, once it's in you, that's the problem.
Yeah.
Right.
It's
It
my
goes- yeah.
concern with other
Right.
injectable drugs. Like I still am hesitant with Xolair for the same reason. You
Yeah.
know, it's a
Right.
monoclonal antibody.
Well,
Once it's in you, it's going to be active for that month.
right.
So-
But one
Right.
of the, oh, go ahead.
Same thing. Well, I was going to say something with the CGRP receptor antagonist class for preventative
Right.
care. They're injectables once a month, and if you have a reaction,
I mean, it's great if you don't have a mast cell
right?
issue,
No,
but
absolutely. Which is why I like the abortive ones.
right, like
instead.
Nurtec, yeah.
Yeah, and I think with the reclass, I think you explained it to me. You know, it's like it goes in you and it titrates for a while.
It does. Yeah.
And as long as
Yeah,
it's
at the time, I
titrating-
looked up the
yeah,
mechanism of action,
yeah,
which I
yeah,
no longer remember.
Yeah.
But
So
that's right. I remember reading about the
said-
pharmacokinetics. It goes up.
and then it levels.
Right.
And you said once it levels off, you will level off because
Right.
your body will have something to get used to.
Right.
But every time it moves, your body is reacting. So that was that journey, and I'm sure it's not uncommon.
Yeah, I'm sure it's not. I mean,
For people like me.
Yeah.
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 but-
Well, for EDS patients in general, there's, as you know, like very often, if not always, mast cell activation. I will say to varying degrees of severity, for sure. Not everyone has such a problem with mast cells when they have EDS, but they are sensitive to usually foods. But many of them are very sensitive to medications. Just they can't
Right.
tolerate most
Yeah.
meds. In fact, very commonly used meds. So some of my patients just can't take them.
Right. And I don't know if I'm sensitive to foods or not. If I am, I don't know it.
Right. Well, you have a fairly healthy diet, so
Yeah, most of the time, not all the time. You know, I mean, I think actually you said in the podcast once, and I thought this is perfect for me. I mean, because I think it's like, can I do it? Will I do it? Can I? Will I? That's what I. And when you said about diet, I said, look, you know, let's just make this simple. It's like, oh, thank you. And if you cannot eat processed foods, check. Low sugar, check. Eat more whole foods, fruits, vegetables, check. Be mindful. Do your best. That's good. I'm like, I can do that. And so, but
such good advice.
but I mean, I remember it. See, and that's what's good. I remember it and I use it.
Right.
So I make choices because, I'm,
Sure.
I did not grow up. You're from the East, I'm from the East Coast too. But, I grew up on Morton TV dinners and,
I'm
all
from
that.
the rough streets, though, of the East Coast.
The rough streets. What did you eat?
The streets of Brooklyn.
Oh, yeah, good old Brooklyn. Yeah. But, so my diet's good. It's not perfect. And
Nobody's
you know
is,
what?
though.
But I don't want it to be perfect. This is where I get back to joy,
Right.
right? If I want to go out to dinner
Yeah, I agree with you.
and I want to enjoy the dinner and, and I say, I'd really love some Alfredo. I have it.
I don't take joy away from you.
I have it. So I do that.
Well, that's a reason to get better.
Right.
If-
Right, so you can have choices.
Yes,
Right,
exactly.
That's the whole
Exactly.
point.
You want
And
to
it's
feel
to
well
have-
so you can go out to
Right.
dinner.
And then I think the other thing is for me, I enjoy, for other people, it's maybe not joyful, but I enjoy walking. I enjoy eating reasonably well. I enjoy feeling well. I enjoy being active.
Hmm.
And so
I enjoy seeing you be well and being active.
Thank you.
So that's the reward for a doctor, right? Is to sort of see the impact that you've had on patients' lives. And I know that you've experienced that as well. It brings us so much joy. And to be honest, it motivates me to continue to do the work that we do.
Oh yeah, I mean,
know?
so for me, so what have you done for me in terms of, I mean, of course you're paying attention, and of course you have to do your job. You have to. There's, if you believe that I have information that you need, and I think you do, then it's a team effort,
Mhm.
and I have to do my part too.
Yeah.
And together we can figure this out.
Absolutely. Those are
But-
the best therapeutic relationships,
Yeah.
for sure.
And so, and as we navigated through it, And then I started to see a little bit of progress. But I think once I got onto the IVIG, it was like liquid gold. Really,
Yeah.
that's what I call it.
Yeah.
Liquid gold for me. And I think I was like, oh, I know what was going on. It's like, aha. Because the inside was fighting everything I was trying to do on the outside.
Right.
So as hard as I was trying to do things to make myself better, the inside of my body was saying, I don't think so.
Yeah.
So did you have a better rate of improvement or a better overall improvement with the IVIG versus plasmapheresis?
Plasmapheresis was 4 times, and it was a preump
Yeah.
to
the
the
IVIG.
IVIG. So
So
the
you can't separate
IVIG,
them really.
Yeah.
I can't
I mean, I'm
separate
just
it.
finding that, and I think I shared this with you already, that, and actually, I think you were one of the first where I started to realize this is the best plan in the world if patients can afford it, which is always an obstacle, but is to, before you start IVIGs, do plasmapheresis, because you just sort of remove,
Cleaning out.
you just clean it out,
Yeah.
right? Otherwise, that's why IVIG is such a long-term therapy, because it's a long-term therapy regardless, but it can take a very long time before you see the clinical benefit. And my theory is that because it sort of has a lot to fight with when it's infused, but the plasmapheresis pre-IVIG just sort of removes all of that stuff, crud.
Right.
And then the IVIG doesn't have as much in terms of like where receptor, like they fight with receptor spaces, basically. So a lot of the things that would fill those receptors have been removed from the plasmapheresis, so the IVIG has an easier time taking a seat. That's how
Well,
I
it
see
uses
Right.
it uses up its ammunition
Right.
before it gets to the real problem.
Exactly.
If-
And over time it will, but it can take 6 months sometimes
Right,
before
which is
patients report
miserable.
any
Yeah.
significant benefit.
Right.
In fact, I often have to basically beg them to stay on it, because they'll tell me at 3-4 months that it hasn't been helpful. And I'll say, we just need to do a couple of more months before we know for sure. But the plasmapheresis has really changed that, because with the plasmapheresis first, it seems that by 3 months, they're actually feeling at least even a small benefit, if not a significant benefit. So I think, but again, plasmapheresis is expensive. It'll never be covered by insurance, as opposed to IVIG, which, we generally
Thank
do,
God.
is covered. So, so if patients can afford a couple of sessions, and I always say 2 to 4, then I really do recommend that.
Right. And that's what we do.
Yeah.
And I think, emotionally along the way, as part of the partnership, I think I had a hard time explaining what I had.
Yeah.
And I thought, I really did. I was like, and I was I felt like I was just going on this long, long narrative. I felt like it was a play. Well, first of all, there's this, and then so
You mean
mast
you're
cells.
saying
The
explaining to family or friends?
Anybody?
Yeah.
Yeah, what I
Because
had.
the whole septad
Right.
is actually, what
Yeah.
I've learned
Explaining
is
it
that it's
was
very
really
hard
difficult.
for patients to explain.
It's very hard. Well, that's
Very
one of the
difficult.
reasons we
That's why I
ended up
did-
doing Patreon.
I know.
That's why we said,
Yeah,
right?
so Dayde and I, we actually designed, we have that new diagram that I was telling you about that I haven't yet shared with you, because I was trying to figure out how to edit it a little bit, but she helped me. She was actually critical in sort of redesigning this whole septat, although we have to come up with a better word now.
Yeah,
I know.
Since
It's the wrong word. I still can't believe
Yeah,
it.
because I said to her,
It's-
I said, narrative. We just need a picture. We just need a picture.
Yeah.
And
I do
A
think
way
the
to
picture is
explain it.
very helpful. A picture's worth 1,000 words, as they say.
Yes.
But I also still think it's hard to explain, and largely because we haven't really yet cemented the connection. I mean, we talk about mast cells, I know, and we talk about how it can basically invoke all these other diagnoses, and I think there's definite truth to that, and I think the research supports a lot of that, but we haven't made that clear enough connection, I think, for it to be like to other doctors,
Right.
most importantly, and then
So-
even to the families of patients. So
right. I agree.
I think
And-
that's what Andy Maxwell's trying to do with
I know.
his spiky leaky
have you
hypothesis.
read that paper?
Yeah.
Yeah, it's
Yeah.
long.
It's incredible.
It's really long, which is why he's having a hard time getting it
Right,
published. But
right.
it's incredible.
And
it
if
really,
he came to the meeting, he's going to give the talk.
that's great.
What's
Maybe we should.
what's the paper
If he's
about?
going to come to the meeting, we should have him here to talk
Yeah,
about
sure.
that paper.
Sure.
Anyway,
What's the paper about?
spiky leaky syndrome.
Which is?
It's so hard to explain.
It is hard to explain.
I mean, I think his slide deck for this is like 100 slides.
Yeah. It's just.
how-
It's really
I don't
hard
want to
explain.
do it in an injustice, so I don't
I
want
would
to
just
even
have
try
him
to
on
the show.
explain it.
Yeah.
We're going to have him
Right.
on to explain it.
But I think one success I feel like I had with a doctor, and I asked him, I saw him last week, and I said, hey, I'd like to mention this. Are you okay with it? And he said, yeah. So, and I said, can I mention your name? He goes, sure, that's fine. And he's really a great doctor. He's the one that told me I needed some Malta. Right, that was the first doctor, and now I've circled all the way back. And in part because of insurance. So Dr. Singh, it's pay as you go, and Dr. Lee over in Evergreen, he takes Medicare. And so for if I need a steroid shot or I need a blah, 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 I go to him.
Right.
And they talk to each other, so it works out great. But I circled back and went, and I said, I'm here. And I could tell by his eyes, it's like, oh, you're back. And I'm like, I know, here I am. And I said, hey, I want to have a chat with you. I said, I'd really like you. This is what I'd like. I'd like you and Dr. Singh to partner. He's like, why do you want me to do that? And I said, because you're Medicare and he's not. And you're a great doctor. You're technically a great doctor. And I know you are. And I know that just because you came to a conclusion that maybe wasn't correct, it's okay because you had the information you had. But now we have more information, and you're willing to be curious, and you're willing to accept that this is really the diagnosis. And I want to thank you for that. And I did.
So
We have a great
Cymbalta
relationship.
wasn't necessarily a inappropriate suggestion.
Right.
It has an indication for pain.
Right.
Pain
Well, I
management.
understand. Yeah.
I don't happen to like the drug for other reasons, but, I think it's one of the few drugs in that category where take this because it's all in your head. It's not that way. It really can help with pain. So just
Yes,
in
it really
defense
can.
of the doctor.
Yeah,
Yeah.
I understand that. And anxiety, I understand. That's kind of a 2-for-1.
Right.
But it was interesting that I could come back
Yeah, it's great.
and have that conversation with him and now have a great relationship.
Yeah,
And
that
when I
says a lot
told him,
about
I said,
him.
hey, I was asked on this podcast. And he said, oh. And I said, I'd like to say something about you. He goes, so you can say I'm a terrible doctor. I said, no, I'm going to say you're an excellent doctor. So I said, no, I think you're excellent. I just think that's a great story because that's what we need. If
For
the
sure.
doctors can be curious
Yeah.
and come back and say, maybe I don't know. It doesn't mean you don't have a problem.
Yeah.
That doesn't mean that. It just means that I don't know what the problem is. And it's okay. And
Right.
I'm not sure. I'm not a doctor, so.
No, I
But
agree.
I
I
think
think that that's a
it's
limitation
okay.
in medicine is that we're sort of indoctrinated to believe that we have the answers to everything and we can treat everything and help everyone. And so it's hard for, I think, a lot of doctors to admit that they don't know or they're uncertain. And also medicine's just really siloed. Like if you don't fit into their box, then they have nothing for you.
Mm-hmm.
You don't agree?
No, I do agree. You know how I feel. I agree, and I find it very frustrating because the answers are all out there.
Yeah.
It's not, I'm not a genius and you're not a genius. I mean, we may be more curious or more open-minded, but I mean, I am searching for things on the internet
All
every
the
day. In
time.
the middle of an
All the
appointment, I'm
time.
looking something up. It's all right there. I mean, I think I've said this to you. I don't think I've said it on camera. I often think, how did I ever do HIV disease those first 15
Yeah,
years? I
without
had
the
no
internet.
resources other than other friends who were equally spending half their time crying over their dying patients without access to resources. Whereas now, I have somebody come in, they have an unusual antibody that I ordered, but I don't really know what it means, and I can look it up.
Yeah.
Right? So when a patient tells me my primary won't prescribe LDN because they don't know what it is, my first reaction, I don't say this to the patient, my first reaction is, that is such a load of bullshit. All you need to do is go LDN on Google and you will get a million hits, and the first 3 will tell you everything you need to know. So that's...
I completely agree. I mean, it really is shocking, like, how little... everything is out there.
It's all there.
I mean, I'm looking up stuff in other specialties that I never thought I would need to know about, right, as a neurologist.
Well, that's part of what happens now.
Yeah.
Suddenly I'm a endocrinologist and a ID, all these other specialties which I
cardiologist,
wasn't trained in. And
gastroenterologist,
figure it out, It's
immunologist, rheumatologist.
not a neurologist. I can't do that one.
Neurology is the black
But
box.
I guess it's frustrating because it is such an incredible resource. Now it's going to explode even more with AI, but even without AI, you can find out almost anything you need to find out, or at least find out enough to ask good questions of somebody else,
Right, and that's another reason why I like our little clinician group. It's not little anymore, but our group, because you could pose questions, and you could sort of pepper people with like, well, wait a minute, that case you presented, what did you do about this? What did you do about that?
Right.
I don't do it as often as I should. You do it a lot.
I do it a lot.
Right.
I do it a lot. And I think actually that comes from the HIV days, because the ultimate, at that time, the only resource I had was a group of about 30 physicians in the Village in Manhattan. And we would meet every month and just go over the cases and say, well, have you tried this? And have you tried that? And did you hear about what they're doing on Long Island? And some of it was talk about weird and wacky. It was totally nuts, but we had patients dying every day.
Right.
And we didn't know what to do.
Oh my God, this is so similar though, right? Because we have patients suffering every day.
Right.
And I think that's one of the reasons why we even started this podcast, because we were hoping we would get a lot more physicians interested to listening to us and sort of maybe engaging questions. But and I think it's happening slowly. I mean, we're very happy having lots of patients because we love to provide information and education and guidance any way we can. But we want like a dialogue amongst other clinicians that are seeing patients like you and like many others, and because we need to share this information, and we need to hear what they think or what they would do or what they know.
Well, that's what was so great. I mean, before this today, we did this Renegade research. Yeah, with like a webinar,
born
Renegade
out of
research.
the remission biome off of, I don't know if you're on Twitter or now it's X, whatever. But I don't know if you're on it or not. But it was Remission Biome. I think it still is on some level. But they started the Renegade research. Yeah.
And this is set up by patients, people with ME/CFS and or long COVID.
It's patient-led.
And on the one we did today, which I think was their first one.
It was their very first one.
There were at least 100 physicians watching.
Yeah.
So it's like, what was your secret? How did you get them to watch? Why don't they watch us?
Because they're only really well known on the X world, which is was what Twitter was, right? And so there's a lot of doctors on. You should go on Twitter. You should be on there.
Yeah.
I learn a lot. I think that's one of the reasons. I really don't know, to be honest, and I don't want to take away from them because they may have other like magic formulas. But I know that they've been very well known on
it's
Twitter.
Great. It's great.
And lots of doctors are on Twitter, so I think that's one of the reasons. But their work has been like applauded.
Yeah, no, it's incredible.
They've done quite a bit.
Incredible.
Yeah. So we had lots of doctors listening and asking questions.
That's wonderful.
And in the end, we ran out of time. Otherwise, there were so many other great questions that we wanted to get to. But yeah, I agree. Dialogue amongst clinicians, there's no substitute for it. Right. Even the internet, frankly, right? Because the internet sort of requires you to really like read articles, and sometimes, from like a more like, I don't know, say like a judgment perspective of like, is this an article worth reading, or how is the methodology done? Is it reliable enough? Like to really do like almost like a journal club analysis of what article is appropriate to take away from and apply clinically. I think that, and the internet, of course, as we all know, is like just full of garbage as well.
Well, it's the internet, but you're right. And the other example of that kind of crosstalk back and forth is Masterminds, our listserv that we talk about, where if I had had something like that those first 15 years, it would have been amazing.
Yeah, I completely agree. So. But that would have required email, and you didn't have
there was no email then either. We're talking ancient history here.
I know, but I will say that also even like you have to be somewhat discerning, right? I mean, there are people that will throw something
Of course.
Like,
All right, well, then I just hit delete and go on,
And then, you learn from experience. Like I learned a lot actually from your trials and tribulations with regards to your response to certain medications, and even that whole mast cell flare that you had after the reclast. And, I learn as I go, right? And so just what I take away from just working with you, I learned how sensitive a body can be to infusions, for example, because, and like David said, I mean, once it's infused, like there's nothing I can do about it. Most oral drugs have a very short not necessarily very short, but a short enough half-life where I could say to you fairly confidently that in a week you'll be better, kind of thing, right? But with infusions, it's much harder. It's like it's sort of stuck in there. And based on its pharmacokinetics, it can take a while to build. Sometimes it builds really fast, but then it takes a while to be degraded and metabolized. So those are the things that scare me when my patients are saying they're getting infusions from other doctors for different reasons. And sometimes, it's a completely appropriate medication and the patient has that diagnosis, and I can't say, oh, don't get that. But it worries me, and I always say, oh, well, let me know how you do afterwards, and I'll help. If you have a mast cell reaction, we'll have to do stuff to sort of help you get over it like we did with you. So I learn from patients just as much. And I know we say that all the time too, but
Well, in
orthopedics, 'cause I
addition
have one
to
here.
learning from patients, I think this relates to something a little earlier we talked about, is feedback from patients.
Yeah.
So, as we have said over and over, almost everything we do is trial and error, partly because nobody fully understands what we're doing. I mean, not what we're doing, but what the pathology is. And partly because all the drugs we're using are off-label. They're not the FDA-indicated uses, which doesn't mean they won't work, but
Right.
it means we need to know. And everybody's different. So,
Right.
pyridostigmine worked for you, but I can give you 10 patients I gave it to where this is going to do it, and it didn't do
Correct.
anything. All right.
Right.
So it's all about that feedback, and that helps to adjust the dosing, or say, well, maybe I need the extended release, not the short release. So I probably drive patients crazy because I keep saying I want the feedback, and then later on I complain about all the portal messages. So it's a double-edged sword.
Just make them really short.
Right.
That's true. Yeah, I like short portal messages.
Yeah. Yeah. And that is part of it, though, the patient, right? We have to kind of participate. And
Right.
Yeah,
I
That's my
try
point.
hard not to bug you too much. And if I do send you a note, I do try to make it like bullet points for that very reason, because I
Yeah.
know your time is precious, and I know you've got so many people and, to take care of. And I'm one of them, and I'm a grateful one. I'm grateful that I'm on the list of people that you're taking care
Well,
of.
I mean, I've always said, like, my patients become my friends, and you are definitely a perfect example of that. And
Yeah.
you've been so great just in your advocacy for EDS patients. And,
Well,
I've had a couple of patients from local EDS groups say that they spoke with you.
Yeah.
And so, and I know you've told me about your advocacy work.
Right.
So that's been a real
Yeah.
important part. I think
I had
also
one
think
do
it's-
a summary for you last week.
That's
she went and I did. And she called and she said to me, "I'm seeing Dr. I didn't even know who she was, and I'm seeing somebody told me Dr. Ruhoy." I said, "I do." And so she said, "Will you talk to me?" And I think I emailed you and I said, "Here's some questions. Would it be helpful?" Because sometimes it's really hard to organize your thinking if you got like a massive data
Right.
and a massive confusion and a massive sense of urgency and angst, and and you're concerned. It's right. The mind gets really they're just racing. And I said, so if I could help organize the thinking, right, in some kind of summary doc, would that be helpful?
Oh, you're so perfectly suited for that.
Well, that's what I did. So what I did
Yeah.
do is so this woman called and I said, and I sent you the questions, and you said, yeah. And I said, we'll do an experiment, right? We'll see if it's helpful or not. If it's not, it's not. But if it was, I'm happy to do it, by the way, for other
That's
patients.
a great idea, actually. It's
I'd
a
love to do
great
that. I know
service.
how to do it. I can distill a lot of complexity. I'm good at that.
I know you are.
So, anyways, this gal, she got on the phone. It was 2 hours, and I just asked her all kinds of. And she goes, "Do you want me to send you doctor's notes?" I said, "No, you're going to send Dr. Ruhoy." I have no idea. I wouldn't even know. No, I said it was just, and I could put it in a management summary report, so you could take a quick look and then zero in. And that would save you probably 30 minutes of talking, and that's
that's
my
great.
idea.
Yeah,
great.
no, I didn't realize that you had written that up.
Yeah, I wrote it.
It's a little like one of the unexpected outcomes I've found with this Unraveled, our Patreon. The patients who have watched it, or patients that are not my patient yet but become a new patient, they are now, I usually ask for a history before I start with a patient, and they are presenting the history now the way I described asking the history in
Isn't
the
that
new
great?
patient episode, and it's like so helpful. It's
Yeah,
incredible.
it's just so great,
Yeah.
Yeah.
And if you guys had like an outline, and this is the executive summary outline. This isn't all the details, right? Because they'll come in with their binders and
right.
everything, and that's your job. And so, but if I could help in that way, that would be great. So when you talked about pivoting or adapting, for me, if I can, it's this has got to be worth something. Me being sick, and it can't just be me being sick.
Right, just
just
not
can't.
about you only.
It just can't be.
Right.
It's just, and so I think that's where a lot of our relationship started. That's where I started about, oh, well, I can make a chart, and I can do this, and why don't I do that? And I, a suggestion du jour, and, but I really like doing that.
Yeah,
And to be fair, I mean, I didn't engage you. I didn't take you up on your offers until I felt like you were stable and improved.
Oh,
because there are a lot
you're
of
so
patients
cute.
that, like, in the throes of their illness, will like offer to help me do something, and I just don't take them up on it because I'm like, I want to focus in on getting you better. I mean,
Right.
you're still portaling
But-
me about severe symptoms that you're having. You can't get out of bed, or
Right.
and I know that they're looking for. I totally appreciate the fact. It's why it's why I do what I do. Like I'm looking to have an impact in this life of mine that I have, however long I have it. So
Right.
I totally appreciate that from patients.
Right.
And I want to give them that, but I also realize that I'm their doctor first,
Right.
and I need to get them to a place where
Right.
I feel comfortable if they wanted to help me out in some educational. It's usually about, not necessarily particularly with patients, but it's usually about on an educational, informational kind of level.
Right.
How can they distill information into something that can be shared, that
Right.
kind of thing. And I don't want to engage them on it until I feel like I've gotten them better, because
Right.
it's a very complicated relationship. But what relationship in life isn't, right?
And I do things outside myself. That's what I want to do. So I mentor, and Connective Strength is the EDS support group.
Oh,
on
is
the
that what
east
it's
side.
called?
It's called Connective.
didn't even
Yeah,
know
they
that.
changed it. They changed it
That's-
from EDS because I bugged them so much about comorbidities.
Yeah.
They changed it, and
Connective Strength.
so
That's good.
That's very good.
so to Connective Strength, and it's just great. And Zoe Jorna runs it. She does such a wonderful job, and they're incredibly dedicated. They do just a wonderful job, and part of it is I can do mentoring,
That's
and
great.
so and I'm happy to do that if it's helpful. And I really am serious. I'm happy to do executive summaries.
No, that's a great
or-
service, actually.
If
Yeah.
you'd like that,
Yeah,
I'd
we can
be
talk
happy
about
to
that.
do that. You just tell me, frame it up and say,
Yeah.
what do you want? And we'll do a couple of experiments to see if it's really helpful. And then if it is helpful
Yeah.
and you want to do that, I'm happy to do it.
Okay. How often does Connective Strength meet?
They meet in Marysville and in Kirkland once a month. And they are releasing a book in May.
Wow.
That's the
You
yeah.
wrote.
I'm in the book, yeah.
You sent me yours.
They wanted to interview me, and so they're doing that. Dr. Singh is very involved with it.
Great. He's
As
amazing.
well. He's amazing, and so they're doing a lot of good work. They're trying to reach out to doctors, and they're really education and support. So they bring
Might be,
people in.
something good for Jen to film
Yes.
in one of the meetings.
Oh, that's a great idea.
Yeah.
She's Well, I know she's going to be here a week in April. We can talk about dates and stuff.
Okay, all right.
Okay. Yeah.
that'd be
Well, that's
great.
exciting.
Yeah, so that's exciting. So, so I am always willing and wanting to help in any way I can because I like doing it. And if I
And
can't,
you're good at it.
I hope I am. If I am and it's helpful, then it's good. If not, then no.
Well, this has been great.
Very,
Yeah,
very
and-
good. So thank you for doing this.
Yeah,
and
we
thank
being
really
you for
appreciate you
comfortable
joining
enough
us.
and confident enough to do this with us.
Yeah,
Yeah.
Really important.
Thank you.
Yeah, you did a great job, and
Oh,
just
good.
sort of talking about your journey and the work that you do. So, and I'm just so proud of you.
Oh, well, I'm so really closing statement. But honestly, thank you from the bottom of my heart, and I'm sure many others. And for those out there, I know the journey can be really, really tough sometimes, and sometimes you feel really isolated and really alone. But you're not. There are ways to connect, and so please reach out.
Great.
Great way to end this
Yes.
episode. So, thank you for joining
Thank you.
us, and thank you,
Okay.
Dayde, for being our lovely guest and sharing